Thank you everyone for joining on this Friday afternoon. Our panel discussion will be about responding to an increased drug toxicity. And I'm joined today with several amazing panelists who I will introduce. So I guess I'll introduce myself. My name's Tiana. I'm a clinical pharmacist at the Center for Addiction and Mental Health, and I'm also a clinician educator at the Leslie Dan Faculty of Pharmacy. And joined with me, we have Matt Johnson, and Matt is a health promoter in the safe consumption site or safe consumption services of Parkdale Queen West Community Health Center. Matt has a long-standing history of working in harm reduction services, as well as acting as an activist to further drug policy reform and improve services for those most affected by the drug war. As a person with lived experience and as an injection drug user, Matt combines their professional and lived experience to fight for a more just and humane approach to health and social services. So thanks, Matt, for joining us. Taryn Lloyd is an emergency medicine physician practicing at St. Michael's Hospital in Toronto. She also works with the substance use support team at St. Mike's Hospital and has a practice at Coderex Medical Center. She is an assistant professor in the Department of Medicine at the University of Toronto and has a Master's of Science in Quality Improvement and Patient Safety. Her professional goal is to optimize healthcare for patients who use drugs, particularly while they're in the emergency department. She hopes to do this by decreasing provider and patient barriers to high quality, timely, and safe and efficient evidence-based care. Amy Noon is a health promoter in the supervised consumption site at Parkdale Queen West Community Health Center, where she supports people who use drugs to safely consume their substances, responds to overdoses, and connects them to health and social services. Her background as a registered nurse from the United Kingdom, where she worked primarily in emergency departments and primary health care. She'll be moving to work as a registered nurse in the Safer Opioid Supply Program in the Parkdale West Community Health Center. And last but certainly not least is Haley Thompson, who is a project manager of Toronto's drug checking service at the CDPE. She's responsible for managing the day-to-day operations of the drug checking pilot, including fostering robust relationships with partners and working with the harm reduction community to optimize the service. Haley's previous project management experience has focused on implementation and quality improvement for primary, acute, and long-term care organizations nationally. Haley holds a Bachelor of Arts in Communications from Wilfrid Laurier University and a Master of Health Science in Health Administration from the Institute of Health Policy, Management, and Evaluation at the University of Toronto. So that is our panelists. And I'll just ask, does anyone have any declarations of interest to declare? Or conflicts of interest? Okay, we're good. Okay, so as I mentioned, today we're going to be talking about the increasingly toxic drug supply, looking at what's in the drug checking supply, in the drug supply via Toronto's drug checking service. We'll look at the changes in the overdose response and the implications that have occurred. And we'll move on to describe what else can be done when we're looking at this toxic drug supply. So I'll start us off with asking the question, what are some of the key factors contributing to the rise in toxicity within the drug supply, and how has this impacted individuals with substance use disorders? And Andrew, I don't think we'll do the slides just yet.
I can speak for this. Myself and Matt work in the same supervised consumption site at Parkdale Queen West Community Health Center. And we worked together throughout the COVID-19 pandemic, where we've seen quite a change in what people are taking. We've noticed that although people come in saying they're going to take fentanyl, there has been a change in the supply, so that in fact most of the time there's a high load of benzodiazepines, as well as other fentanyl analogs, tranquilizers like xylazine, and sometimes the response that we would have traditionally done to respond to a fentanyl overdose is no longer working to the same extent that it once did. So we use primarily naloxone and oxygen to respond to opioid overdoses. And we found that what we used to use no longer has the same effect. We're finding that people are, their oxygen levels are increasing, their respiratory rate is improving when we give them oxygen and naloxone, but they're staying unresponsive for long periods of time. And that's, we think, primarily due to the large amount of benzodiazepines that we're seeing in the supply right now. Yeah.
I would say, I mean, so criminalization, I think, is obvious. Christy Sutherland apparently talked about this for a little bit before, so I'm not going to go into that too much, but like obvious criminalization, but also like unfettered capitalism and globalization. So unfettered capitalism at home and like an austerity agenda has ripped away the services and the welfare state that we built. So from post Second World War up into the 70s, we had built a pretty robust welfare state that we spent the 80s and 90s just stripping away until it's just like a shadow of its former self. And so, you know, our housing is in a crisis. Our hospitals are in a crisis. Like our mental health services are in, like all of these things combine to make this a much harder problem to address. I think unfettered capitalism also addresses this because like unemployment is connected to high levels of substance use. Like all of these other effects of austerity agendas and people feeling dehumanized and depersonalized in a capitalist system is more likely to cause people to use substances in the way which we're most focused on, right? Like the majority of people use substances recreationally. We're really focused on this small percentage of people who use drugs like all the time. I think capitalism also has a big part in it because the unregulated manufacture and trade of drugs is a completely unregulated hyper capitalist environment where fentanyl in some ways was an inevitability, right? Fentanyl is so much cheaper to produce, so much more potent, therefore so much easier to move around the world and move across borders, that why would they not move from heroin to fentanyl? It only makes sense for them. And that's why we keep seeing more and more stuff being added, because like any good capitalist, they're looking to minimize their expenditures, maximize their profits, and that's exists above all else. And I mean, drugs make more money than anything, I think, except oil in this world. And so it's a very lucrative trade for the people who have that amount of wealth and power that they can get into it. I think globalization is added into it too, because at one point the drug trade was a little bit more cut off from each other. You had entities, cartels that would closely guard their access and their supply routes, and that's really shifted when different groups from around the world now work with each other. And so we have precursor chemicals from China that get taken to Mexico to be turned into fentanyl analogs and then shipped into North America. And so the global trade of like licit and regulated product has also opened up a more global trade in illicit products. And I think that the trends around drug use have shown that out. And there's an amazing book by this Italian journalist who originally wrote a book on the Camorra, the mafia, who now has lived the rest of his life in hiding. He wrote a book on cocaine, and he talked about how some police organization managed to get a listening device into this meeting where this old mafia guy was running a training school for other cartel organizations, like young cartel organizations, teaching them how to be better at this. And so there's a level of, like, I think, cooperation among groups that there maybe hasn't been in the past. And there's so much profit now that it's like, it's in some ways easier to collaborate than it is to fight each other. And so again, you see, like, Russian subs have popped up in Colombia to move cocaine into North America. So there's like cartels are working with each other to like maximize profits and in ways that we just haven't seen before. And then our policies just drive that, right? Like we had fentanyl that was coming directly from chemical factories in China. And then the Trudeau government, for some reason, decided to try to crack down on that. And so they made it more difficult for those factories to just manufacture fentanyl. Well, then it moved to from these gray factories to complete black market in cartel-owned territory. But also we moved from fentanyl, which has been used medically for over 50 years, and we have a really good idea of how it works. And we have anesthesiology journals that talk about the effects of it and stuff, to fentanyl analogs that have never been used medically, to xylazine, which has never been used medically, to like all these other things. And so our policies to try to, every time we try to crack down on the current drug supply, causes the cartels to move to something that is significantly more dangerous for the people who actually consume the drugs. It's better for them because it's usually easier, cheaper to make, and makes them more profit, but it's the human cost is always going to be higher.
So thanks, Matt and Amy, for touching on this multifaceted, I guess, background in terms of why we're seeing this increase in toxicity. I think this is a nice segue for Haley to talk a little bit more about Toronto's drug checking service, what the service is about, and then also kind of what you've been finding.
Absolutely. Well, my slides are, there we go. Amazing. Thank you so much, Andrew. So hi, everybody. My name is Haley, and I'm the project manager of Toronto's drug checking service. I just have a few sort of like housekeeping slides I have to get through. So at the start of the presentation, we said, or all of us said, that we have nothing to disclose. I have no commercial support to declare or conflicts of interest. I and Toronto's drug checking service have not received funding from a commercial organization or product that will be discussed in this program. And then for interest, I just included our members, our partners and collaborators, and our core funders on this slide. This is also available on our website on our About page. I also wanted to share some acknowledgements. So I want to acknowledge the members of our community that have lost their lives, both in the ongoing drug poisoning crisis and long before, due to policies of drug criminalization. I want to acknowledge that the land on which we operate, Toronto's drug checking services, is the home of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I want to acknowledge that racialized communities and survivors of colonization are disproportionately impacted by unjust drug policies. And lastly, in our presentations on drug checking, we go over a lot of data, and it's really important to acknowledge that that data is connected to samples that people who use drugs willingly submit to us, and that there are a lot of adverse health outcomes that are associated with those samples, including both fatal and non-fatal overdoses. So it's important to acknowledge that while what we're looking at is graphs and lines on a page, that there's people in pain behind the data I'm going to present. So Toronto's drug checking service is, as it sounds, in Toronto, and we're part of a suite of harm reduction services that are available here in Toronto. And while, we still don't have enough even in Toronto compared to a lot of other communities in Ontario and undoubtedly across Canada, we have more than many. So I won't go over them, but they're sort of at the top. What is particularly unique about what is not particularly unique about drug checking in terms of harm reduction, but what drug checking does is that it offers a free and anonymous, neutral public health service that recognizes that people are owed the dignity of knowing what is in the drugs that they're using. And I thought Dr. Christy Freeland did a really good job of talking about this in terms of using the analogy of alcohol, or comparing it to alcohol in terms of, people are able to know what it is that they're consuming, or cannabis. So anyway, yeah, so drug checking offers people information on the composition of their drug sample that they've submitted in order to help them make informed decisions. In addition to the results of the drug checking analysis, people are also offered strategies to reduce harm. With all of the individual drug checking data we get, we collate that and we share it and provide drug market trends information. So while our service is currently the only operational service in Ontario, people from anywhere in the world can go on our website and sort of know what it is that we're finding in the samples that we check here in downtown Toronto. What drug checking does not do is it does not condemn or condone the use of drugs. It does not classify a drug as good or bad, and we do not tell people what to do based on those their analysis results. People are free to make autonomous decisions as to how they want to use that drug and what they want to do with that drug. A question the service often gets is, there are other data sources out there in terms of what is in the drug supply, like drug seizure data, coroner's data, urine drug screens. And while that is true, all of those data sources only present combinations of drugs. And if there are, I guess what I'm trying to say is they don't know the expected drugs. So they can only comment on what drugs are present, but not what was expected, and therefore the level of contamination of that expected drug. So that's very unique to drug checking services. Although, sometimes urine drug screens are in real time in terms of when we look at aggregate data, so not the individual. A lot of this data takes months and months to turn around, and we take the responsibility of getting the data and what we find in drug samples checked back out to the community really seriously. And we're able to, we share data bi-weekly. So every other week we update our website on information from the drug supply. I mean, the drug market changes day to day, but unfortunately we're not able to update it that quickly. And then I've touched on the public dissemination piece, and that we just, we share quite regularly. Our service. So I've mentioned that we are free anonymous public health service. Our main funder was the Substance Use and Addictions Program at Health Canada. They funded us from February 2018 till January 2023. We actually only became operational in October of 2019. That is due to the fact that there were a lot of processes that we had to get through and exemptions that we had to get in order to be able to run the service. So we have been operational since October of 2019. Our funding commitment from SUAP was up in January of 2023, and we're actually operating currently without a long-term funding commitment. But our hope is that we can sustain and beyond that scale the program to other parts of Ontario. We use, and I'll get into this in the next slide, but we use what's known as an off-site drug checking model, meaning we use laboratory-based technology. So samples are brought from our collection sites. There's 5 community health agencies that offer supervised consumption services. They're along the bottom of the screen there, in which drug checking is embedded within. And then those samples are collected 5 days a week, Monday to Friday, and brought to either CAMH or St. Michael's Hospital, where they're analyzed using either gas or liquid chromatography mass spectrometry. And I saw earlier one of our amazing lab folks, Dr. Sarah Delaney at St. Mike's on here, and I know Dr. Christiana Stefan is presenting a little later, both of whom are very involved in our drug checking service, our members of our drug checking service. And lastly, I'll just say that we do this we provide drug checking services to inform individuals and also to inform care for people who use drugs, advocacy, policy, and research via the information we disseminate publicly on the unregulated supply. So I mentioned off-site drug checking, and I wanted to get into this a little bit more because it's important as drug checking services expand and as the monitoring of the unregulated drug supply expands across the country with different services popping up. It's just important to recognize sort of the benefits and limitations of various technologies and our program. So one of the benefits of our program is that we're not only able to analyze substances, but we're also able to analyze used equipment. So for some people, giving up 10 milligrams of their substance, which is what we request, is a little bit too much for them. They're not able to do that, which is totally fine because we analyze used equipment like used cookers, cottons, liquid from a syringe, and in some cases, pipes as well. The technologies that we use, the gas chromatography and liquid chromatography mass spectrometry, are highly sensitive. And why this is really important in the context, especially of checking opioids, is because a lot of the drugs that we call noteworthy, which means that they are highly potent, that they may contribute or result in adverse effects, or they may not be desired by the person using the drugs. We know that a lot of these drugs are being found in trace amounts amounts. So having a technology that isn't highly sensitive, that can't find drugs in trace amounts, means that you'll be missing them in terms of the individual analysis results you provide, as well as drug market monitoring. These technologies can break apart really complex drug mixtures and differentiate between drugs, and that are really chemically similar. And this is important if you think of something like fentanyl and carfentanil, where they're very structurally similar, but obviously the outcomes of those drugs are very different, carfentanil being 100 times stronger than fentanyl. These technologies have comprehensive libraries, and they're able to detect rare and new drugs, meaning that if something has just popped up in the supply, the likelihood that these technologies will catch them is quite high. And they're also able to provide precise quantification information, and we'll get into that a little bit later as well. But what we know from the community is that ideally people would be able to have precise quantified information for all drugs found in a sample, because this would be much closer to being able to access a regulated supply, or like knowing what is in the drugs you're taking, and therefore making the most informed decision. The limitations of using these sophisticated technologies are that they're not portable, so they're not easy to move, and therefore they're mostly found in clinical laboratories. They're destructive, so people, if they are able to submit a substance to us, they're not going to get it back. Turnaround times for results are 1 to 2 business days, Monday to Friday. So yeah, we know that for a lot of people at highest risk of overdose, that's too long. And ideally, there will be technologies that come out in the future, and I think we're going to talk about that a little bit later as well, that are able to provide the type of results that these sophisticated technologies are within a shorter time frame. These technologies, or the techniques that we're using, cannot identify non-drug filler. And we recognize that a high barrier to accessing them is that they're expensive and they require extensive training to operate. So I know this is fairly technical, but I think it's important because as I go through the data on what we found in the supply, it's important to acknowledge that we wouldn't be able to have as precise of information that we do without these really sophisticated laboratory-based technologies. So when we check a sample, we ask the service user what the drug was bought or got as, and if that drug is the only drug found in a sample, we say that it met a service user's expectations. So they expected it to be methamphetamine, and methamphetamine was the only drug found. And as you can see from this slide, methamphetamine is actually the drug that is least contaminated. So over 80% of the time, the only drug found in an expected methamphetamine sample was meth. Ketamine, 71%, cocaine, 67%, crack cocaine, 44%. And you can see then when we get down to opioids, people's expectations are rarely met. Heroin, 1% of the time, only heroin is found. For fentanyl, it's 6%. And sorry, so this is just really important when you think about just, what else we're finding, or when we're talking about the toxicity of the supply. Slides jumped around a bit, my apologies. So I'll just say that all of the information that I'm going to be walking through, including the previous slide, all of this information is available on our website, drugchecking.cdp.org. We have a lot of interactive graphs and tables there if you want to get familiar with what it is we're seeing in the supply. So focusing back on this slide where we look at just how infrequently fentanyl is meeting service users' expectations, I want us to start by looking at the actual quantity of fentanyl found in an expected fentanyl substance. So we are able to provide that quantity-based information for people. And what we know is of the 10 milligram sample that somebody submits of fentanyl, the average amount of fentanyl found, and I say average, but we actually use median, is 420 micrograms in a sample, which is equivalent to 34 to 42 milligrams of morphine in a sample. We know that MME equivalencies is something that a lot of clinicians are familiar with. So, we like to sort of translate that into something that people can understand. If we extrapolate that out to an assumed daily dose, that's approximately 42,000 micrograms per day, or 3,360 to 4,200 milligrams of morphine per day, depending on, the assumed range. We assume that fentanyl is 80 to 100 times stronger than morphine, so that is what that range is sharing. And we know that currently, for a lot of safer supply programs, the maximum dose or MME equivalency people are receiving is about, in Dilaudid, is about 1,200 milligrams of morphine per day. So, you know, with the current safer supply options available, we know that many people's needs are going unmet, and we share this empirical data in an effort to try and, you know, get us closer to being able to meet people's needs, and therefore have them not need to rely on the unregulated drug supply as much, if at all. So sharing, that's sort of like the base of where we're starting in terms of fentanyl being found in an expected fentanyl sample. So that is the drug that people were expecting, and that is the drug that they got. But as we noted, 96% of fentanyl substances don't meet people's expectations, and there are other drugs being found in fentanyl. The drug we find most often in over 90% of samples is caffeine. While you know, we know that caffeine, most people wish that caffeine was not in their fentanyl. We don't consider it noteworthy in comparison to the other drugs that we see alongside fentanyl. So here we have a time series graph of the noteworthy drugs that we found in expected fentanyl samples over time. You'll notice that benzodiazepines we see in about 50 to 60% of expected fentanyl samples we check. We also see other fentanyl analogs, carfentanil, nitazene opioids, xylazine, and synthetic cannabinoids, much less than the others, but they do pop up from time to time. I just want to draw your attention in particular right now to the fairly dramatic increase in fentanyl analogs presenting. So you'll see that right now the amount of benzos being found in expected fentanyl samples and fentanyl analogs in addition to fentanyl are about equal. What we know is that, and so sorry, I'll say that this slide is just kind of a gradual transition from that, and just that the other fentanyl analogs that we're mostly finding in addition to fentanyl are other high potency opioids, whether that be fluorofentanyl, which is a family of fentanyl analogs that are roughly as potent as fentanyl, or bromofentanyl is a fentanyl analog that we're seeing increasingly present in expected fentanyl samples. It's in between morphine and heroin in terms of potency, and then nitazene opioids, which range in potency from around the same as fentanyl up to 10 times stronger than fentanyl. So these are the additional high potency opioids we are seeing in expected fentanyl samples. And this graph here just really shares that we're seeing an increase in the number of high potency opioids presenting together. So you'll notice there's a decrease in the number of samples containing just one high potency opioid, and a fairly steady increase in the number of samples that contain at least two high potency opioids. So again, increasing that MME equivalency I'd shared on the first slide, that isn't even being considered because at time we're not able to quantify these other fentanyl related drugs. The reason, so we kind of talked about this in terms of like, why is the drug supply increasing in toxicity? Suggested reasons are the iron law of prohibition. So as we start introducing more and more policies that aim to suppress or reduce the supply, what we see is an increasingly potent supply that is trying to sort of curtail or skirt around the policies that are being introduced. Also, as people continue to use fentanyl year after year, their tolerances will be increasing, and the market may be trying to better meet people's tolerances as well. What Amy and Matt spoke to at the beginning of the presentation, the real outcomes of this are extreme sedation. So people being sedated for a lot longer, dangerous suppression of the respiratory system or vitals, and increased need for naloxone and oxygen for longer periods of time in order to reverse overdoses and stabilize people. I also spoke to the fact that benzodiazepines are a drug a group of drugs that we see regularly present in the fentanyl supply. Some people refer to the mix of benzodiazepines and fentanyl as benzodope. The suggested reasons for why benzodiazepines are being added to the fentanyl supply is that fentanyl is so short acting, and in order to sort of better replicate the desired effects of opioids like heroin that used to be in the market, benzodiazepines are added to, quote, give it legs, or just to extend the desired effects. But what we know are that the real outcomes are, again, prolonged sedation, increased risk of vital suppression, and benzodiazepines carry with them a high risk or potential for dependency. The graph on our right shows over quarters sort of the presence of benzodiazepines in expected fentanyl samples. And I just want to note the variability. So at times we've seen benzodiazepines only present in around 30% of expected fentanyl samples. On average, it's about 50 to 60, but we've also seen it go as high as over 80%. So if you're somebody who uses fentanyl and you do or do not know that you're even consuming benzodiazepines, there's a high risk that you may become dependent on them. And when benzos are only being found in the supply 30% of the time, you may actually be experiencing benzodiazepine withdrawal because benzodiazepines aren't being found in the fentanyl that you're purchasing that frequently. And then in turn, when benzodiazepines are presenting in 80% of expected fentanyl samples, if you're somebody who is lucky enough to have access to a supply that benzodiazepines aren't being added to, you're going to have a really hard time finding fentanyl where benzos aren't present. So, the variability in terms of when these drugs present and their potential for dependency, we hear a lot of people who say, I now feel that I am dependent on benzos and I never even wanted to be consuming them in the first place, but I have no choice because I don't have access to a regulated supply. Unfortunately, you'll notice on this slide, so much like that fentanyl to morphine equivalency slide that I presented earlier, we did the same for atizlam. Atizlam is a benzodiazepine-related drug that presented in the supply for a very long period of time, from when the service started in October of 2019, all the way up until like late 2021 or early 2022. Again, because of the nature of an unregulated supply, atizlam has almost dropped off completely in terms of the benzodiazepines we see, and we now more frequently see a drug called bromazlam, which is said to be sort of equivalent to Xanax in terms of just being a high potency, short acting benzodiazepine related drug. We're hoping to quantify it, but it's very hard to stay on top of what is being added to the unregulated supply. All to say, unfortunately, we don't have that data on bromazlam at this time, but we do have the information on atizlam, when atizlam was being found in the unregulated supply. And what we know is if we were to extrapolate out what we see in the samples checked to a gram, an assumed low daily dose, we know that the equivalency of what people are consuming in benzodiazepines in their fentanyl is about 22 milligrams of atizlam a day, equivalent to around 100 to 200 milligrams of diazepam a day. And again, just to say, this is in addition to the fentanyl that is being found in the expected fentanyl, as well as the potential other benzodiazepines and other high potency opioids that we see present frequently in a single sample. Sort of the last of these sort of spotlights that I'll do is xylazine. I think xylazine's been getting a ton of media attention recently. And while I do think it's important to share information on what we know about it, I think focusing on these one drugs, these one sort of like, high alert drugs takes away from the bigger picture, which is that the supply overall is very contaminated and that people don't have access to anything different. So while it's important to share this information, it's unfortunate that people still have to use the supply that is contaminated with these drugs. So xylazine is an animal tranquilizer that has not been approved for human use, but it is regulated in a veterinary setting. So it's been suggested that it's being added to the supply, much like benzos, to give the fentanyl legs, but that maybe it's a little easier to access given the fact that it has use in veterinary medicine. Our colleagues in the States, in cities like Philly, they see xylazine present in approximately like 90 or over 90% of their fentanyl supply. We don't see that here in Toronto, nor do our colleagues in BC, but it does present regularly, usually in around 10% of fentanyl samples checked. But as you can see on the slide on the right, in xylazine presenting in expected fentanyl samples by quarter, there's been a lot of variability in terms of the amount of samples that contain xylazine over time. So much like benzos, xylazine contributes to prolonged sedation and increased risk of vital suppression. But unlike benzodiazepines, are unique to xylazine, I guess I should say. Xylazine has been noted to be associated with skin lesions or bad ulcers. In the case of the States, there's been some reports of amputation, and this is because it's a vasodilator, so it would be cutting off oxygen to the skin, or blood flow, sorry, to the skin. So overall, I just wanted to bring people's attention to sort of the growing toxicity of the supply. I think I've tried to highlight sort of the variability in the supply, but also just to say that we're seeing these drugs present more and more, the number of drugs presenting in samples is increasing fairly dramatically over time. So in the just under 3 years that our service has been operational, we've gone from seeing 4 drugs presenting in samples associated with overdose to more like 10 to 12 samples that are most frequently in samples associated with overdose. So, just to make a note that the supply is continuing to change, and what we're seeing is that it's actually becoming increasingly more toxic. So I know that's a lot of information, a lot of data that I've spewed at you folks. So I'll pause there, and we can go back to the questions.
Tiana, we can't hear you.
Thank you. I just wanted to say thank you, Haley, for giving us that comprehensive overview of what's being found in the drug supply here in Toronto. And so I think now maybe we'll move on to look at how the change in the drug supply has changed our overdose response, and some of the key strategies and interventions that have been implemented in order to address this change. And perhaps we can start off with Amy and Matt to look at, specifically in a supervised consumption site, how have you guys had to change how you're responding to people experiencing an overdose?
I mean, I think Amy mentioned before that naloxone just doesn't work like it used to, because fentanyl may not be the main drug that people are intoxicated on, and we don't have flumazenil in SCSs. It's just like, because it causes seizures, it's kind of too risky to use outside of a hospital. So we don't have a benzo antagonist. I don't know if there is a xylazine antagonist. There probably is, but we don't have one anyway. So, we need to rely on oxygen more, which isn't maybe by itself that big of a deal. Like, we tended to be pretty oxygen focused to begin with because we're trying to avoid putting people into withdrawal. So we're always oxygen first, oxygen only if possible, and then use naloxone only when it's absolutely required. Where it's caused a lot more issue for us is that people are now unconscious or heavily sedated for hours at a time in SCSs, and SCSs were really built with heroin and then fentanyl in mind, so they weren't set up with the idea that people would be with us for hours and hours and hours. We don't have space to put people, it was also, and if you look at a lot of SCSs have time limits, like a 20 or 30-minute time limit, where you come in, you go to your booth, 20, 30 minutes later you have to leave. That's just not possible for anymore. Definitely not for us. But then, so it's having people in booths for a long period of time, which then cuts off other people who can't enter the space. But it also has an impact on staff. There's a much higher staff turnover than there used to be, and certainly closing is much harder than it used to be, with people not being awake and being able to leave on their own. And then we have no choice but to rely on EMS transport. And then unfortunately, the emergency 911 system sort of doesn't know we exist, or like they don't treat us any differently. So that whole process is an explanation every time about how this isn't a regular OD call, like this isn't an emergency, we just need transport, because we don't really have a better option. We recently in Toronto have the stabilization center opened up, which is a much better option for people than just sending everybody to an ER, because they don't really need an ER, right? Like they just need to be monitored. They're usually physically fine, but the stabilization center only has a few beds. It's really limited. And so it puts a much higher strain on staff than it used to, when there was just much more in and out, and ODs were intense but very short.
Yeah, I 100% agree with what Matt's saying. I think that it's harder to manage people in this space. The actual supervised consumption site that we work at is quite small, so we have only 4 booths where people, if the audience, if no one's been in a supervised consumption site before, it's the area where people will prepare their drugs, cook them up, and then usually most people inject them. And it's usually the area where we respond to overdoses. We do also have an area that's going to be a chill out space, but unfortunately getting people moved from a booth to this sort of chill out space is nearly impossible when someone is completely, comatose. You can't, physically having to move them just to create some more flow within the space is really challenging. And we can have certain days where, as Haley had mentioned, where the drug supply, is particularly been so heavy, or there's more xylazine or more analogs of fentanyl. So the type of overdose response will really change. And a lot of people will buy from the same supplier. So you'll end up that everyone or near everyone that day will need some sort of response. And like Matt mentioned, we really try to do the least invasive approach possible. So we really try and rely on oxygen more. We don't want to send people into withdrawal. We also want to encourage people to come back and use our service. So we don't want to go heavy-handed with things like naloxone, because that's a lot of people have experienced being sent into acute withdrawal, and then they don't want to come back and use the service. They want to enjoy their high, right? So it's that getting that balance where we're trying to allow as many people as we can to use the service, but also move people along, and that just becomes really difficult when we're seeing the kind of overdoses that we are of late. So yeah, I guess SCS is really, if this is a drug supply continues to be the way it is, and it has been like this for the past few years, maybe the setup needs to change, so there's more space for people to just, kind of wean off the benzos that are in their system. And like Matt said, closing time is becoming harder, because we do close at a certain point. We're not 24 hours. And then we have to, unfortunately, rely on places like EMS and emergency departments. And a stabilization center is a great alternative, but like I said, it's only 10 beds for the whole city. So it's trying to find alternatives that are safe for people. And then when people leave in a state, they may be able to talk to you, they may be able to stand up and walk, but how safe are they to really leave our service? How are they going to get back to where they're staying? Have they got someone that they can go home with? Is that person also in a sober enough mind to be able to walk back safely? I mean, we found a lot of people get assaulted, sexually assaulted, physically assaulted, robbed when they're in this state, which is really, really worrying.
And I think to go on with what Amy was saying, there's the people who use our services are having a harder time, because benzos and xylazine can put people into blackout states. People are kind of like losing periods of time, not knowing what happened to them. Amy mentioned the assaults and the robberies, but also just losing stuff, like putting a bag down and walking away from it because you're not even aware that you have a bag or where you are. And then sometimes people are in that state when we shut down. So they may be up and talking, but they may not really be in consensus-based reality, and we have to have a hard decision. But if we call 911, if EMS comes, they're often with it enough to be able to say, I decline medical services. But if we see them later on in community, they might be passing it in the middle of the sidewalk or walking into traffic or something like that. And so it's really freaky letting people go when they're able to decline medical services, but they're so sedated that they may not be able to, like Amy said, get where they're going. And then I think too that we're seeing the result of hypoxic brain injury in a lot of people. A lot of the public health messaging around responding to overdoses is old, and it's based on fentanyl. So it's like, check if somebody's breathing. If they're not breathing, do X. And they haven't really updated. So if people are just really sedated on benzos, they may be breathing and taking good breaths, but only breathing twice a minute. So their oxygen levels are too low. And so we're really worried about this. If people go into this state of low oxygen once, it may not be a big deal, but if it happens day after day after day, week after week after week, that's enough to start to have an impact on people's brains. And I've seen changes in long-term community members who I can see them starting to lose their memory, starting to like lose impulse control, things like that. And so I'm really concerned about people's brain health long term. And then again, with the public health messaging that hasn't kind of updated, is again, it's just this reliance on naloxone only. But if you're just naloxoning somebody who's sedated on benzos, you can give them dose after dose after dose. It's not gonna change anything. But we haven't sort of told people what else to do instead. And again, to focus more on like rescue breathing or airway management or anything like that.
And I guess I'm wondering too, Matt, like the difference in that public health messaging from like in the SCS versus like just for lay people in the community. Do you feel like we should be promoting kind of giving rescue breaths when we're talking to like lay people?
Yeah.
And then obviously in the SCS kind of promoting airway management and oxygen.
I mean, I think public health often has a really crappy, sorry, I'm trying not to swear, really crappy view of lay people and their abilities. So this idea that like lay people can't be trusted to do a pulse check, lay people can't be trusted to do rescue breathing. I was a lay person until I started working in safe consumption sites, right? Like I don't have a medical background. I just have spent 6 years, 7 years doing only this. But like it didn't take me 7 years of doing only this to learn how to give mouth to mouth or learn how to do a pulse check. It doesn't take a whole lot. So, and the other thing is that it's not really the lay public that is most likely to be finding people and responding. It's most likely going to be friends, like other people within the community. It's going to be other people who use drugs. It's going to be other staff members, like staff from shelters or staff from drop-ins.
Mm-hmm.
It's not going to be like, you know, an accountant by day, like soccer coach on the weekend who like lives in the suburbs in Vaughan and is at the mall and just happens to find somebody ODing and dying. Like that's possible, but it's just way, way less likely than it is going to be people who are around people who use drugs a lot. So it's not like we need to educate everybody. It's a smaller proportion of the population. And I think anybody who works with the community that we work with should be doing advanced CPR training and should be doing all these things to get better than just like nasal naloxone and that's it.
Mm-hmm. Thanks for sharing. So maybe we can go to you, Taryn, and maybe get a little bit more about what you're seeing in the emergency department.
Yeah, thanks for that, Shannon. Everybody, I completely agree. And I think what we're seeing in the emergency departments is really just a reflection of what's also happening in the community, but perhaps later on in someone's course or trajectory after having used drugs or having overdosed. And I'm always very mindful of that in the emergency department. We're aware that life has gone on before they've entered the hospital, and often they're coming in after some interventions have already been started or tried, and they're ending up in the hospital for a reason. But we're seeing in terms of the overdose response, we're seeing the same thing. So again, naloxone isn't what it used to be. We still use it, and when it does work, we are sort of anecdotally using it in higher doses. And then I think that largely depends on the variability in the supply. So if that particular overdose tends to be more opioid driven, then they are requiring more naloxone. But what we're used to see was often a very robust response to naloxone, both from a respiratory return, but also sometimes quite a lot of agitation, and a lot of withdrawal. And we had actually cut back on the naloxone doses, and we're sort of giving small doses in efforts to try and avoid putting somebody into significant withdrawal. And those days are not the case anymore, or very rarely the case anymore. You might improve somebody's respiratory efforts or rate and oxygenation, but they don't often wake up. And we're seeing the same prolonged downtimes, hours and hours, and sometimes over many shifts. And also anecdotally coming along with that sort of prolonged excessive sedation. Again, we're anecdotally seeing lots of increases in terms of airway interventions. So patients requiring excessive monitoring and supportive care in more critical care environments, whether that's in the emergency department or being transferred into the ICUs, simply because they're so sedated and they're not breathing even after naloxone. And we think and suspect that that's from all the contaminants in the supply. We don't use flumazenil a lot. I know it came up, Matt, thank you for bringing that up. We also don't use that a lot in the emergency department because it still has an incredibly high seizure risk. If somebody has been exposed to this supply for some time, and we saw that in our results, is they've often been getting benzodiazepines of varying kinds and quantities for a long time, and the risk is quite high with giving flumazenil to actually worsen their situation overall. So we're not using it as an anecdote the way we would have, the way we would naloxone or Narcan. So that's it's an option, but in these scenarios is not being used that frequently. I also just wanted to say that we're seeing, I think attributable to the varying supply, we're seeing a lot of other medical presentations. So seizures in scenarios that don't typically cause seizures. So, somebody used what they thought was XYZ substance and it's not, and they're coming in sometimes with quite prolonged, significant seizures. And we see things like hypoglycemia more than often. So what sounds like more of a sort of typical, putting quotation marks, overdose. Naloxone's given, airway supports are started, and people are having like prolonged hypoglycemia that doesn't respond as quickly to administration of glucose the way we would see. So we're seeing these other more variable medical problems that are arising. And again, I suspect we think it's from the just varying supply in what people are using or not necessarily intending to use, but getting exposed to. So yeah, we see these big things. The other piece I want to say is just outside the overdose scenario, it has changed our population. So people are presenting for other various medical reasons, and things like managing acute pain in this population is something that we're mindful of. People coming in with broken arms for whatever reason, even unrelated to drug use, but if they're being exposed to these toxic chemicals and their drug use otherwise, they require higher doses of analgesia just to simply manage pain, things like infections. So there's another side to our role in the emergency department that even outside an overdose scenario, we have to be aware that our community is being exposed and having these sort of toxic chemicals in their body, and that changes their response to other medical interventions. And we've had to adapt, and I think we're still in flux. For example, there's limits in the hospital to how much opioids you can give with any one dose, and those are largely historic and driven by policy, but working hard to try and lower some of these barriers by removing maximum doses that are arbitrary for some reason, that don't necessarily apply to everyone, and just trying to be mindful of the change in these types of things when people are presenting for medical attention.
We've also seen an increase in infections and wounds and things like that at the health center.
Yeah.
And also, people, just what you're saying about the realities that you face as a prescriber in the emergency department when we have people that have infections or another health concern. People who use drugs will also hurt themselves, break their arms or whatever. And, we have to sort of recommend, with this injury, you need to go to the emergency department. And, people don't want to go to hospital. And one of the many reasons, but one of the big ones is that they are concerned that, how will my pain be treated? How will I be able to continue to receive my own medication, my personal medication that I use to keep myself well? So it's even from on our perspective, it's that those are concerns that people have before they even reach the hospital, right? Like it's something that is
Absolutely.
hard for them.
I think if you looked at Haley's numbers around, like if somebody's taking a gram of fentanyl a day, it's the morphine equivalent of like 3 to 4,000 milligrams of morphine, roughly. Like, I feel like these are like tolerance levels that we didn't imagine like not that many years ago. And the highest tolerance that from a prescription I think I'd ever seen before the fentanyl hit was somebody was on just over 1,000 milligrams of morphine, and that was just like, whoa, it's like that's so high, and the prescriber was actually very uncomfortable with it and was trying to taper the person down a little bit. And now we're like way beyond that, but I'm not sure if enough people in the medical world get access to those numbers like Haley has to like recognize like how far we are past what was assumed to be opioid tolerances. Like it's a whole different world.
Exactly. I think also, and this is related, but just touches on the other sedatives that are in the supply again, even outside an overdose scenario, we face the same challenges where people might come and they're awake and they're talking, but it's unclear how much they will remember or how much they can sort of understand at that time. And so we also have lost some of these windows for potential interventions or even offerings. For example, we've increased some of our substance use support. Peer support workers are available during set hours, working on that piece as well. But even some of the supports that we've tried to build on and have available for people it's a limited opportunity to provide it when I think with all these different chemicals and the toxic supply is impacting people's ability to actually engage in some of those interventions when they're in those scenarios. And again, we're seeing the same things. I think that even outside hypoxic brain injury, just being exposed to these benzodiazepines, other chemicals, I think there are effects on health that are long term that come up in these other ways that are maybe less dramatic than an overdose or in a scenario where somebody has to be intubated and goes to ICU, but have these insults to their physiology and their cognition that ultimately change the way that they can engage in both healthcare and other supports in our traditional model, right? Somebody might not, I guess an example would be somebody can't sit for an hour and engage in a conversation and make decisions about certain care pathways or things that they'd like to see for themselves when they're simply under the influence of all these chemicals that they never intended to use in the first place. And it just has changed the way I think we can support and help the community in that sense.
Yeah, I was just talking to a colleague at a different safe consumption site who was talking to a community member who had said, oh, I've been doing really well. I haven't overdosed in a couple of months. And my colleague had to say to the person, no, you've overdosed 5 times this week here. And he had no recollection of that. And so it becomes really difficult to try to like talk about just basic safety if people have no recollection of how many ODs are really happening in their life.
Exactly. Yeah, we're seeing the same thing.
All right. Thanks for a really great discussion. I think we've highlighted, how difficult it is to identify like what exactly is happening when people are presenting to the emergency department or after consuming even at a safe consumption site, what exactly the person needs, and then just really identifying a lot of the gaps in our existing system. So this brings us to our halfway mark in the talk. So perhaps we'll go for our 10-minute break and then we'll see everyone back around 3:30. Awesome. Thanks, everyone, and welcome back. A part of me wishes you could have been there during our break because we had a really fruitful discussion and really just kind of seeing the devotion and advocacy that comes from this group of panelists is really, really amazing. So we were just talking a little bit in the break about kind of some of the complications that happen when people are in hospital, and then also some of the reasons that people are not going to hospital. So perhaps we can continue and restart that conversation for our attendees.
Matt, do you want to start with maybe what the conversations you're part of or what you're hearing before people will seek care or are willing to come to seek care?
So there's a lot of complications of trying to get the folks that we work with into medical care, particularly into hospitals. People have had historically not great interactions with hospitals, and one thing that's unfortunate, I've said this a lot when I've talked to doctors, but also when I've talked to like police, is like you individually might be like the best, most understanding person in the world, but people have a relationship with the institution you work for, and so people are going to interact with you as the face of that institution, and you kind of have to go in understanding that. And I work in social work, and we have an awful history. We're responsible for the 60s scoop and residential schools and all kinds of stuff, right? So I've regularly had to like acknowledge this like tragic history and like apologize for people's terrible treatment from like colleagues of mine in order to just like start an engagement at all. And I get that kind of sucks, but it's necessary if you want people to come in. But yeah, like those kind of negative interactions really they hurt, and they really sit with people, and they really drive people's later decisions. And then often they're compounded, right, again and again and again. So people have a lot of concern that their pain won't be treated properly. If you're using drugs, your tolerance is going to be probably way higher than doctors are assuming. Again, looking at Haley's stats, 3,000 to 4,000 milligram morphine equivalent. And so, if my tolerance is up there and I break my leg, I might need thousands of milligrams of morphine, not like 100. But not all doctors are necessarily open to that. And also hospitals sometimes have policies that put a cap on things like that. So definitely people's pain not being treated properly. We've also had clients on safe supply who have been taken into a hospital and taken off their safe supply in hospital, which is a surefire way to get people to leave against medical advice, like AMA. If anything, people's safe supply maybe needs to be increased when they're in hospital. You also have the particularly the homeless drug using community is a community that and people are used to being around a lot of folks. This is one of the things that makes housing people really difficult, is people are often living with a lot of people around them, and then you try to house them alone, and it's incredibly isolating. And you might think, well, wouldn't you want privacy and all that stuff? And it's like, well, maybe, but it's also just not what you're used to. You're used to having people around you all the time, and it gets very lonely. The hospital's the same way. So people often have their friends come in and visit them. Well, sometimes those friends are bringing drugs in or whatever, and so hospitals have barred visitors to a lot of the folks that we work with, or kicked people out because they're using drugs in the hospital and basic things like that. And so it stops people from wanting to go to begin with. And we have a hard time even getting people to see our in-house physicians, which is just to go up to the second floor. So we'll have a client come in who has a incredibly serious infection. The nursing staff of the SCS assesses it, realizes that they'll need injectable antibiotics, so they need a prescriber. So it's like go up to the second floor, and that's a barrier that's big enough that that some people won't access it. So we have to have our prescribers come down into the SCS to see people, and so these barriers are just become like compound and become insurmountable for some people. And then as a person who uses drugs, you're so over surveilled and you're treated like garbage everywhere you go. The last thing you want to do is bring yourself to a place where you feel like you're going to be treated even worse than you are on the street corner. There's a lot of language that's used that can be used in the medical world that's incredibly hurtful. Things like frequent flyers, or talk about like this person's a waste of a bed that could go to somebody who's more deserving. or drug seeking. Drug seeking is a big one, and that kind of thing gets put in your chart, and it's really difficult to convince anybody to take you seriously after that. And I've certainly had that happen in my life. In the break we were talking about, I had an interaction with a doctor. I had pretty serious pancreatitis and was in a ton of pain, and they were like, we've hit the limit of morphine we can give you. And I was like, but you're basing that on the amount of morphine for like opioid naive people. I've been a professional for years, so like, don't treat me like I'm in the amateur class. I'm a pro, right? So give me the good drugs, which they wouldn't. But like for me and a lot of other people who have been long-term opioid users, some kind of serious painful event that puts us in the hospital is a huge fear, because we know we're not going to get the extra medication that we really need, if they can even find a vein in me, which is maybe not super possible. And so, we really need to switch things up to make the hospital, like, kind of like the SCS, like we do a lot to try to make the SCS a fun place, like a place that people want to be or feel comfortable. And I'm not sure if hospitals have done enough at this point to make the hospital a comfortable place for people who use drugs to be. I'm not blaming anybody in particular, because what sucks is that one hospital staff says something mean, sorry, I'm trying not to swear, says something mean to that person, and that might be enough to be like, well, forget all of you, so I get it's tough, right? Like, because you don't control what everybody says or what everybody thinks. Also, as a long-term drug user, because you're overly surveilled, you tend to get really good at figuring out what people are thinking about you or how they really feel. And so you might not say something to somebody, but if what you're thinking is, this person's difficult, this person's asking for too much, they should just be happy with treating them at all, or they're a waste of a bed, like, people will get that, and they'll leave. And we have so many of our folks who leave against medical advice and come into the SES, and we're like, how did you leave? How did you physically leave? You are so unwell. You shouldn't be able to get out of the bed and walk. But people sometimes have tremendous, like, the willpower to just do incredible things to get out of places that they don't feel safe and don't feel comfortable.
I would just like to say one little thing about this, just to back up what Matt's saying before we talk about it in the emergency department, is that, like, even when you see people who have, for example, like a wound or something that needs antibiotics or it needs treatment, just trying to get people on board with a treatment plan. So say using a particular type of dressing, or bringing a nurse practitioner or a doctor down to review their wound and to maybe start antibiotics or something like that. All of those things are like, can be just hurdles. And, you've really got to get a good rapport with that person in order that they can trust you. And Matt's completely right. Like, people will have, like, straight up assumptions about you, or, they don't trust you at all just because you're presenting as that professional. So it can take, certain, someone might come in and they have a problem that needs to be addressed right now, but because of the way they've experienced their previous interactions with healthcare providers, you won't actually get to do anything with that, say, wound for another week or so, because they might come back every day, and each day you're being like, oh, can I have a look at that? What do you think? Oh, no, next time, tomorrow. Or you might have to speak to them and say, like, okay, what have you been doing so far? And, in your mind as a professional, you might think like, wow, okay, you've been picking at it with your, potentially unwashed hands, or you've been lancing it with, a needle or something. In your mind, you think, okay, that's maybe not the best thing to do, but you have to, meet that person where they're at, and, understand that they're being resourceful. They're using what they have available to them. And as Matt mentioned before, especially people who use drugs that are unhoused, they're in that sort of close network community, and they're using, maybe they don't have access to wash their hands, or maybe they don't have access to sterile equipment all the time. So it's sort of like acknowledging the limitations they have, but also sort of respecting people that they're doing the best they can. And yeah, just hopefully, that they'll come back and see you. And eventually, in the SCS environment, we do build up that rapport with people, that we do eventually build up that trust, and they do want to come in and respect our opinions on things most of the time. And then we use that to then, say like, okay, I think now we're at the point where you really need to go into hospital, right? And you need to see someone who's an expert in this, and that's how we kind of build up to that with people. Because if you straight up say to someone, no, that needs intravenous antibiotics, you need to go to hospital, they'll just say, no way, I'm not doing it. So
I just want to say one last thing about hospitals, and that's the method in which people are ejected from hospitals. So we've often had folks that we've managed to convince to get to the hospital, and then they end up getting removed and beaten up by security guards. And it's way more common than I think people recognize or know. But then, how do you get past that barrier when it's like, well, we want to send you to the local hospital? And they're like, well, last time I went there, the security guards beat the crap out of me. Like that's such a hurdle. Like how there's no way past that. And so it's not just the fear of being judged, it's not just the fear of not being treated well, it's like there's a real safety issue for people in trying to access things.
Yeah, absolutely. Thank you both. And it's very complex. I'm not sure where to start, but I think that you're right. We little by little, each interaction is one thing, and it's a whole system. It's individuals within a whole system that ultimately have to change, and we have to do things differently. And some of it is the stigma and the discrimination and the microaggressions that happen, or the way things are said, or the way things are done. And then there's a huge other side to it that is just how hospitals function for everyone. And regardless of if you use drugs or not, they're not necessarily comfortable places. And especially the emergency department these days, beds in hallways, bright lights, sounds, there's all sorts of things that are just really terrible for any human being, that exist because of some of the strain that we're under. But I think it's not an excuse. I think we need to do better for everybody, but especially I think these things trickle down, and you walk through the hospital or the emergency department at midnight, and most of the patients in our hospital, in those beds in the hallways with the flashing lights and the terrible situations, unfortunately, are people that are there because of the consequences of the toxic drug supply. They're those patients that are there for hours and hours, because they've had contamination in their drugs. And so I do think that I acknowledge it's not great for lots of people, but I do think that particularly this population kind of gets the brunt end of the stick in many different ways. And we need to change a lot of it. The environment and the way we address care in this population just fundamentally sort of needs to shift. I always use this example because it's so basic in a lot of ways, but it's very complex. So for example, when we refer somebody from the emergency department for follow-up care at, say, a wound care clinic, they get a phone call within a few days for that follow-up appointment. That just happened. That's the way the system works. But not everybody thinks to check. Does the person even have access to a phone? Do they have a phone number that they can be called? They might not have their own, but perhaps they go somewhere every day that has a drop-in line, or has, maybe they go to the safe injection sites. Like, there are ways to address this with individual people that it takes a little longer. So sure, I guess in a busy in apartment, sometimes it gets missed, and I'm not by any means perfect. I miss these as well. But I think this is a perfect example of just a small way that we need to shift our traditional model of care that we provide for people within the whole system, from the emerge to follow-up clinics, etc. That just requires slightly different thinking and a slightly different approach if we want to actually make a difference for their outcomes, or get them to that follow-up appointment, as a very tangible, specific example, and not by any means to simplify it. But these are the types of little things that I think really make a difference, or can make a difference. And over time, we need to shift the shift the culture to better approach this. And I think that need has only been accelerated, again, just coming back to the toxic supply. This is always, there's always, in my opinion, been a lot of barriers between the community and the hospital. But I think when you add in the supply and the current problems that we're facing, it's really just really shone light on some of these inadequacies or deficits that have existed for a long time, and trying to rebuild some of that between the hospitals and the communities, both individually but also from a systems and policy levels.
I say too, it's difficult. I mean, the time you have to, the wait times in hospitals is difficult for anybody, but for a lot of the folks that we work with, they may need to be constantly making money to procure the drugs that they need in order to just be well. And so the idea to be like, go to the hospital for 12 to 20 hours when you can't make money, you can't meet the deal, like that is not possible for lots of people. And we don't necessarily, like, safe supply is great, but it takes a while to get on. So we don't have like a stopgap, like let's prescribe you to keep you here kind of thing. I saw that there was a question, is there a liaison between the clinic and the hospital? And the short answer is no. The long answer is that like we have taken that on sometimes, like SCS staff have certainly done that, and we'll try to do that if we think it can help. And you know what, honestly, it really does. A lot of the time, a lot of the time, if people have a person who will go with them, they're way more open to the idea of going, especially somebody who's like a staff member who they think may be able to be a buffer and be not treated as badly. But we don't have staff who are paid to do specifically that job. So instead it's if we can spare an SCS staff member to do that, and it just really just depends on the day. So we can end up kind of maybe prioritizing the most extreme, most highest need, when really it would be a need for basically anybody.
Matt, just to add on to your point, I think it's really funding dependent. And I mean, as in the community health center, everything is funding dependent, but there are case managers and there were health navigators as part of the Safer Opiate Supply Program at our community health center, part of Queen West. And often, because we shared a lot of clients that are part of the supervised, that use the supervised consumption site, but are also on the SOS program, we could sort of, bridge the gap and try and liaise with that program to get their health navigators or case managers to support our shared clients, even if it wasn't something specific to the SOS program. So for example, someone needs to go to the emergency department, but they're not always available, and there's no case manager or health navigator for our individual program because there's no funding for it there. So it gets a little bit complicated, but it often means that unless there is a free member of staff, as Matt was saying, there is no one to take them.
And there is an SOS case manager, but it's one case manager for the whole program. Exactly. So that's one case manager for 200 clients. Like that's that. So again, it's if they're available. Also,
and
just
if
like
you're lucky to be on the program.
Yeah. I'd also just to say one more thing about the ERs. That's a challenge, is that I think we're really focused right now on fentanyl use, but we have to remember that like people are polysubstance users, and so there are lots of different reasons why the ER might be difficult, and ERs are especially difficult for people who use stimulants. They're just not set up to be places for people who are really high on stimulants, particularly people who are ODing. When I was trained, and when I train other staff in responding to stimulant ODs, our go-to is to bring people to a very quiet, calm place with maybe like lower lights, talk very quietly and like calmly. And the ER is the exact opposite of that. Like Taryn just said, like there's flashing lights and stuff like that. And so if people are brought in really high on crystal, because crystal is so good, we're not really worried about like other additives in it, but it does make the ER potentially really difficult place for people to be. And it's no wonder that people then sometimes end up having interactions with the staff members there that end up having security guards get involved, which then doesn't necessarily go well. I'm not sure if security guards are always trained in extensive de-escalation tactics or techniques. and working with people who are really high on crystal.
I also just want to say, like, I completely agree. And the other piece I forgot to mention was just that the under recognition of symptom management and withdrawal, like suspecting withdrawal. So if somebody's sitting and waiting for 8 hours and they typically would use substance, so whether that's opioids or other, at certain intervals, part of why they might be agitated or irritated or lead to these situations is that there's an under recognition and under treatment of both symptoms and withdrawal. And I it's complex. It's not always the case, but I think, for example, there's been lots of attention to treating alcohol withdrawal in the emergency department, but far less attention to treating people coming off of stimulants or people that are not in overdose, but are coming down from other opioids and the sedatives in them, or even people that are using benzodiazepines intentionally, but are no longer at access to what they usually would use, and they're going into these scenarios. And I think that's a really, again, sort of smaller piece of this puzzle, but we can recognize that and treat that before it leads to these scenarios that are really, really harmful and traumatizing to patients. And I think that, anyway, that's just another piece that I think sometimes I've had my own patients tell me they can't go to the hospital because they might have an hour and a half or 2 hour window where they could come in comfortably, but they know that it's going to exceed that. And whether or not they even want to disclose their use, because there's lots of reasons why somebody might not even disclose their use of drugs. Their symptoms will go untreated, whether that's pain, anxiety, withdrawal. We have directives at triage for people to get Tylenol and antiemetics for people that are nauseous, but we don't have these other things that, if we treat it early enough, could actually be smaller problems before they escalate into these really traumatic scenarios.
So I think you guys highlighted all of the barriers about coming into hospital. So when people come into hospital, maybe what are some of the complications that you guys have seen, perhaps from extended stays or being admitted to the ICU? And then perhaps we can talk a little bit about your older patient population, what you're seeing kind of related to the toxic drug supply.
I can maybe start just from within the hospital. So patients are simply with us longer, and I totally acknowledge I'm mostly in the emergency department, but I have lots of colleagues in the internal medicine wards or various wards, particularly people coming in after trauma or requiring ICU stay. They will end up with prolonged complications. So again, if you're being intubated after an opioid overdose when otherwise you would have been given a small bump of naloxone and on you went, it opens you up to all sorts of other complications associated with those interventions. So prolonged infections, so not just simple like skin infections anymore, but prolonged pneumonias, endocarditis, bacteremias. And associated with prolonged downtime, we also see things like rhabdomyolysis or like injury, muscular injury, depending on positioning when people are down. If they've been down in certain positions for a long time, we can also see neuropathies. So people can end up with peripheral neuropathies or even longstanding deficits related to nerve injuries because of positions secondary to prolonged downtime. So we see these other complications. And then again, I really think we can't underestimate the effects on people's cognition and memory, both from the toxicity themselves, but also any potential hypoxic brain injury or time spent in supportive care environments. We know even outside for people that don't use drugs, there's these sequelae of medical complications that come. And so this group is just being exposed to that more often now because of requiring more medical intervention. And then they get discharged. And the other piece I think we talked about, and I think it's worth adding, again, I'm not in this world that often, but for somebody leaving an ICU stay for other medical problems unrelated to substances, they may be offered certain rehabilitation programs. So there are inpatient rehabilitation programs in the city or even outpatient groups for things like addressing cognition, building up muscle mass again, building up energy, managing the recovery from a chronic illness or acute medical illness turned chronic while in hospital. And I'm not sure that those resources are as robust or as offered as openly to people that have been in that scenario because of substance use. And sometimes substance use can be a barrier or perceived as a barrier relating to the stigma around it, and certain programs may not always be open to accepting folks that have those things on their chart. Again, going back to some of that stigma that might follow people through their medical journey. So I don't think they get as much support post-hospitalization for various reasons as well. And I think then they end up back in the community, and perhaps Matt or Amy or any other folks can comment more on what they're seeing when people come back out of the hospital.
I'm going to let Amy mostly talk about this because I feel like she knows a lot more about this than I do, but we do get a lot of people who are released from long stays without like a robust plan for leaving. And then I just wanted to say that like we're not doing well as a society in terms of the health and longevity of homeless people. Like the expected life age of a homeless adult is like 59. So it's you know, sorry, it's either 59, no, it's 49. Anyways, but it's just under half of what it is for housed folks. So we're not doing well. This isn't on hospitals, it's just on our whole system. Not doing well at keeping homeless people alive for anywhere near the rest of us. And so people who are homeless may be more likely to enter the hospital with a whole range of issues like Hep C, diabetes, all these other things that would maybe like complicate what they went in for if it's not one of those things.
They also struggle as well, you know, to attend follow-up appointments for certain things. I can think of clients who have required like a surgical intervention and then would require to go to like sort of like a fracture clinic or have follow-up with their surgeon or something like that. And like to even like, you know, we spoke about the toxic drug supply. We spoke about the effect of things like benzodiazepines and long-term use of that. You know, for people to remember appointments, if you think about how much like benzodiazepines they're taking every day, and having like, you know, like episodes of amnesia, there's long-term memory issues that we're seeing anecdotally, and like people don't remember, you know, the basics days of the week, that type of thing, never mind, oh, I have a follow-up in, you know, a few weeks time. You know, and we do a lot to remind people like in our work, you know, oh, you have an appointment next week or then, or, you know, to try and support people as much as possible. But yeah, and that's on top of the people, you know, are unhoused and don't have somewhere where a letter can get sent to them, you know, to receive that information, or they don't have a family doctor. So just to speak to that point, in regards to like our clientele, a lot of people that we see are, you know, have been using substances for quite a number of years, and we have quite a few people that are in their sort of late 50s, early 60s. And for someone who, you know, a lay person, that might not seem that old, but when you have been, you know, using substances, and on top of that, you know, perhaps like living outside or living, you know, not in your own home, perhaps having health concerns that haven't always been addressed in those early stages. And then on top of that, dealing now with an increasingly toxic drug supply, the end result is we have a lot of people that have sort of small issues that maybe began small that have now developed into something like a lot more serious. Taryn, you mentioned about people that had, you know, that would fall asleep and be in an awkward position and then would have nerve damage. You know, that would take months of rehab, you know, for some people. And people that haven't been able to manage to do that, you know, have problems with, you know, being unable to do daily tasks of living and have problems with dexterity because their arm is no longer functioning and their hands no longer functioning the same way that it once did. And then how do they go about, and you know the possibility of working is a challenge. The possibility of just doing normal daily activities of living are also difficult. And then, you know, we have people that have we talk about in medicine, you know, when someone is elderly, they have problems with like kidney function, etc., and how how when you take certain medications, how those are processed in the body and excreted. When we see people that are using these mass doses of the equivalent of morphine and equivalent of, diazepam, I anecdotally see people that are, having lots of periods of blackouts, and, they may also be on prescribed benzodiazepines that their prescriber doesn't know about too, and other medications that we don't know the interactions with. And this polypharmacy type of situation between the toxic drug supply and prescribed medications is also something we take consideration. And yeah, we've had clients that have, ended up having blackouts. We don't know whether it's because of an overdose or perhaps it's maybe a hypoxic brain injury. It's sometimes hard to know the chicken or the egg situation, but the end result is people are in hospital for extended prolonged periods of time. They're perhaps discharged to, supportive living center, or even some cases like a nursing home environment. But those places are tend to be far away from where they were living before. They tend to be disconnected from the community members that they once knew. We've had people that have absconded from these places and just been missing people because they don't know where they are, and they're far away from where they were living before. And all those things are something that we're seeing more and more often.
I also think you shouldn't underestimate the impact of trauma and grief on people's health and on longevity. And anybody who uses drugs or has used drugs in the last few years has likely lost people. Like everybody that we work with has had many, many, many losses. And anybody who works in this field has had many, many, many losses.
Attention, there's a medical emergency at the front of the building.
Sorry about that.
Emergency, if there's any staff available, to kick them down and support us. Thanks.
Sorry about that. So the impact of having all of your loved ones die, or have, so many people die these sudden deaths, and then the grief of living with that, has a huge impact on people's health and well-being. And it's difficult because it's not as simple as an infection where we can prescribe antibiotics. Like grief and trauma are, with the best care, take potentially decades to deal with, and for people who are in really great life circumstances, take decades to deal with. So where do we even begin with people, and how do we continue to have people maintain hope in a world where there's such a good chance you're just going to die? I mean, it's a very dark and depressing thing to think about, but that's the reality of what's out there right now.
Yeah, thank you all for sharing your perspectives on this. I wonder now if we can we circle back to the beginning and think about how drug checking services have been useful for your clients, but then what other people are you seeing kind of using drug checking services at the safe consumption sites?
I mean, drug checking has been enormously helpful, and we.
Oh, looks like he's frozen. I can continue that.
So funded to go forward. Our agencies put the money in to try to keep it. Oh.
You froze, Matt. Sorry. Yeah, you cut out. You might need to start again. Sorry.
Oh. Yeah, we're just so frustrated and dumbfounded that drug checking hasn't been funded moving forward, because it's been so incredibly helpful. Our agency actually put some money in to try to keep it going a bit farther, because it's been such a game changer. So for the people we work with, I mean, the turnaround time means that people can't make a decision about the drugs they're about to use, but it does allow people to make decisions about, like, I'm not going to go back to this dealer, or I'm going to go back to my dealer and be like, hey, this is the stuff you have. You got to do better. It gives people information and options, and I gotta tell you, if one person is known to have like a bad bag out there, like that's really bad for them. So dealers will take that information and try to shift things up. It also gives us an idea of what's trends are going on, which is enormously helpful. I mean, Amy mentioned before about how we'll see a batch that's hit because we'll have 4 people come in, and then boom, 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 they all go down at the booths at the same time, and they all have the same stuff. It gives us an idea of like what we should be thinking about for the future. So like when benzos hit, like I was working in these services before we had benzos in supply. That would have been really, helpful to know ahead of time. The ebbs and flows of xylazine are really helpful to know. When there's new high potency opioids that come out, that's really helpful to know. Like all of that stuff. And then that's just around fentanyl, but there's also a huge number of people who use just our drug checking services. So we get a lot of people who come in who use ecstasy, cocaine, ketamine, like hallucinogens, who are more like party users. So they're more likely to go buy like a few $100s worth of drugs for a party that's happening next month. So they will get all of their stuff tested and then not use it until they get their results back. And those people are completely opioid naive. So if they did get something that had fentanyl in it, they would have no tolerance and would for sure overdose and potentially die. But then there's also a whole bunch of potentially toxic stuff that can be in other drugs that's not fentanyl based at all. Like there's a bunch of stuff that's been in ecstasy before, like DOM that has killed people and things like that. So we have a whole bunch of recreational drug users who use our services and only use drug checking. And a lot of those people, we ask them, have you ever used harm reduction services before? And a lot of them say no, because they're not the people who we've historically tried to target with harm reduction services, because they tend to be well housed, well fed, and like working and healthy. And people don't sort of pin them as people who use drugs, but like they need access to safer snorting supplies, they need access to pipes, they need access to all that stuff. And so it's been an incredible tool to reach out to that community and to keep that community safe as well.
Yeah, I can also, I mean, it's so great to hear from our sites and our partners in terms of, because they're, they're working directly with the service users. As the coordinators, we don't always get that opportunity. But sometimes we do. And to Matt's point, yeah, like I mentioned earlier, like 45% of what we check is fentanyl, approximately 50% are opioids. The other 50% are made up of other, stimulants, psychedelics, depressants, you name it. We've checked wide array of things. And yeah, to Matt's point, 38% of people who have used our service have never used harm reduction services before. So this is like a massive amount of people in the community who may not use safe consumption services or even have associated with harm reduction services before that are now coming in, seeing what they're about, understanding how they work, and will likely access them in the future. And I think also importantly, we'll go back to their communities and talk about how great these services are being offered locally, right? So it's kind of like this ripple effect that happens with drug checking that we think is really wonderful. And to Matt's point, like, yeah, there are noteworthy drugs that we see in other drug types as well. Like there are 2 drugs in particular, like phenacetin and levamisole, that are the main noteworthy contaminants of cocaine and crack cocaine. And maybe on a one-off, they're not that bad. They don't pose that big of a risk. But if you're using these substances over time consistently, yes, they do contribute to, like in the case of phenacetin, renal complications, potentially failure, potentially cancers. It was actually a fever reducing medication, or an NSAID, that was taken off the market. I think it was like in the 80s or 90s. And then we see levamisole, which is actually an animal dewormer. It has been known to contribute to wounds and skin necrosis. So we focus a lot on opioids because as that slide I presented shows, definitely opioids are more contaminated than other drugs that we check, but that's not to say that they're the only drugs that are contaminated. Other drugs can be. I also want to add though, I think there is, at least from the data that we have through drug checking. That's all we can speak to. But, you know, there is this sort of like public discourse, and I think the media doesn't help the situation in that fentanyl is in everything, opioids are in everything. And that's not to say that there is never an issue of contamination, of opioid contamination of other drug types ever. There are. But one, if that does happen, if it is purposeful, like that doesn't make sense as a business model, right? If you're a drug seller and your clientele is somebody who purchases stimulants or psychedelics, or even depressants that aren't opioids, it doesn't make sense for opioids to be in there. That's not going to produce the end result someone wants, and especially if that end result is death. So when they do present, we recognize that it's accidental and it's contamination. And I think a lot of the sites are doing a lot to kind of educate sellers around best practices to reduce contamination. But also, so of all of the non-opioid drugs we've ever checked, less than 1% have contained high potency opioids. So that's over 4,500 samples we've checked. Less than 1% have contained high potency opioids, as well as the expected drug. So I think it's important that we sort of address the misinformation that is out there that fentanyl is in everything. I mean, what we can all do is incorporate harm reduction measures into our drug use, no matter what drug we use, and try and reduce the potential for overdose. But I just think this idea that opioids are in everything, it's part of the work we do as drug checking is to share back with the community how little that happens. And so we think that's a huge benefit to the community as well, in terms of like how drug checking is impacting folks outside of opioid users necessarily, and even outside of people who may use the service directly.
I'm really glad you said that, because another thing that drug checking does is it's one of the only things that's allows us to interact with drug sellers and get dealers to come in. A lot of what we offer isn't very attractive to drug dealers and can be seen as scary because it's like a heat thing. And we unfortunately often have this narrative that like people who use drugs, these poor victims who are preyed upon by these like evil predatory drug dealers. And that's not the case at all. We have a lot of people who sell drugs who come in and use the service to get their drugs tested to make sure that what they're selling is good, or that at the very least they can tell people like, hey, be careful of this, or like this is what you need to watch out for with this. I just read a newspaper article yesterday where they stated that drug dealers are putting fentanyl into the crack supply to try to get people dependent on crack, because crack doesn't cause a physical dependence. And I don't know where they get this stuff from, but yeah, that's just never been the case. Nobody buys crack with fentanyl in it and then goes back. So, but yeah, we need to do better at reaching out to drug dealers and making friends with them, and having drug dealers be a part of the harm reduction conversation about how we can improve health and well-being for everybody.
Matt, I was just going to say, just to your point, we also post like the drug checking information. We get reports from the drug checking service on a regular basis, and we write that up on like a whiteboard within our SES and within our harm reduction room. And I know other sites do something similar. And not only is that, education and information for our clients, but also we've even had people like paramedics, when they've had to come into the SES to respond to an overdose, actually like take a photo of that information and be like, wow, that's so super helpful. Like, I didn't even know this service existed. And, just through word of mouth, I think within a professional context, sharing the benefits of having the drug checking service and having that knowledge can help us, look after people who use drugs, and help when we're responding to overdoses, or we're responding to someone who, who requires a medical intervention,
Yeah, we include it in our like department newsletter I think it goes out every month or so, but partly for awareness and just I think it helps to build like some truth and credibility around the advocacy work that we do, just because it's data, it's live data, and we see changes over time. And anyway, it's incredibly important for all the same reasons, but we definitely share it within the emergency department as well.
I think just to close that question too, that I'd really like to drive home in terms of like, what does drug checking service do for clients, for the community, whatever. It's like, people are owed the dignity of knowing what is in the things that they're putting into their body. And the idea that we are the only service in the province and one of few that are as robust in the country is really sad. And I think we need to recognize the mass amounts of people that are putting things into their body because they need to be well, that have no idea what is in them. And, I've been on webinars, and I've heard people who are in, more privileged positions, let's say, who use fentanyl, who are able to buy in bulk and who have avoided becoming dependent on benzodiazepines because they can access drug checking and they can check what they're using and they can not expose themselves to benzos. That's an incredibly privileged position to be in if you're somebody who is dependent on fentanyl. And the idea that, like, yeah, we are without a long-term funding commitment, and the idea that we could not be in existence in a year, it makes me really sad for all of the people that use substances and therefore have to access them from the unregulated supply, and therefore don't know what exactly it is they're using.
I want to add, and I don't mean to derail the conversation because this is a whole other topic, but as in my other role in my substance use practice and addiction medicine practice, when I'm prescribing certain medications, we still do urine drug screening, which again is a whole other topic. But I've had many a patient who can't access drug checking services for various reasons, and they are incredibly interested even in the results of their urine drug screen. Mostly for this reason, I completely agree. People deserve to know what they're using, and of course, after in their urine, it's after the fact. But I still think it's incredibly useful and just sort of interesting to think about that people are even very interested in their broad spec results from their urine drug screens.
Awesome. So before I thank our panel, if you guys have any questions or comments, feel free to enter them into the chat. And then I just want to take the time to thank you all, our panelists, for your passion, for your advocacy, and really everything that you do. You've highlighted a lot of gaps in our system and also made recommendations on kind of what we can do to make people's lives better, including if anyone in our attendance has the capability to advocate to continue funding for Toronto's drug checking service. I think that's one thing that we definitely all see a benefit from. So we've done a lot. There's definitely a long way to go, but I appreciate everyone taking the time on your Friday to listen to us speak. And yeah, I hope everyone has a great weekend. Feel free to comment in the chat. We'll be here for a little bit longer as well.
I'm hopeful people jump in if they need to, but I just have to say it's such a privilege to be here with you folks. Thank you for this time and prep, and also today. This is great. I hope we can continue lots of these conversations. And anyways, just grateful.
Absolutely.
Yeah, thanks for that, Taryn. I mean, as somebody, because drug checking technically works out of St. Michael's Hospital, right? And we chat a lot with sort of the harm reduction committee in terms of like what we would like to see the hospital do from our perspective and stuff. And I think, as a hospital that is the inner city health hospital, there's just so much that we could do to be the best inner city hospital. I hope. Yeah. Anyway, I really hope, like, I don't know. I like the idea that St. Mike's could be a great inner city hospital. I want to see that happen.
Yeah, huge topic and conversation. I agree. I'm 100% on the same page. there's lots of work to be had, but we certainly have a lot of interested, passionate people that are knowledgeable and can make this happen, and definitely room for improvement. We just need the right supports and timing, but I have not lost hope. We just have lots of stuff to do.
Long way to go.
Long way to go, exactly.
It's hard because like I mean, the institution I work in isn't as big as St. Mike's, but like when you work in a big institution, you often have a lot of really great radical people who are all on board. But it's like getting the institution to shift. It's like a big lumbering beast where like it takes so long for it to make any steps. When it does, it can like flatten mountains and like move rivers and do these amazing things. It just takes so long to get a big institution
Absolutely.
kind of moving.
Yeah, and unfortunately, I hate to keep harping on the pandemic too, but the pandemic also really put things back, just because of the nature of being a hospital, and obviously the responses were necessary and stuff had to happen, and I get all of that, but I think it put a lot of this work back, unfortunately, and so we're restarting conversations and restarting and trying to get that momentum and get that support going and start to put time and energy and money towards things that are not COVID related.
Also,
Sure.
it's a particularly scary time right now because there seems to be this like concerted effort from a more right-wing anti-harm reduction group of people who are working together to make an argument for why all these services should be shut down. I don't think it's a coincidence that the National Post released a bunch of anti-harm reduction articles the same week that Pierre Poilievre put forward a bill wanting to dismantle some of our services and stuff. So it's a really scary time right now for how the future is going to go.
I think it's also quite ironic considering that, I mean, I think we all know people that work in this sector that, you know, if anything, although the world's paused or stopped during the COVID-19 pandemic, people still continue to use drugs, and the drug supply, as we've all mentioned, became more and more toxic, became more and more volatile, and the overdose crisis continues, if not gets worse. So like, you know, as we talk about these institutions playing catch up, because obviously they had to for the reason of the pandemic, put a pause on things, you know, meanwhile, like the opioid crisis is getting worse, right? So, and then coupled with what Matt's saying about, you know, changes in politics, you know, and lack of funding for drug checking services, it paints a sad picture, you know. But as long as there's people still having these conversations, especially across services, like it's been great. Like we work with Haley, but it's been great working with you, Taryn, as well. Like, you know, seeing faces in places that you don't get to, you know, to see and have these conversations, have the opportunity to do it. So it's been great to do that today.
Yeah.
Completely agree.
So yeah, thank you everyone for joining, and we hope you all take care, and we hope you enjoyed our presentation.